Your blood pressure medication is doing exactly what it was prescribed to do. It is keeping your heart from beating too fast. It is lowering your blood pressure. It is reducing the workload on your heart. All of that is real, and for many people, it is genuinely life-protecting. But there is something else it is doing. Something quieter, something that has nothing to do with your heart and everything to do with your legs. If you are over 60 and you take a beta blocker, Metoprolol, Atenolol, Carvedilol, Bisoprolol, Propranolol, your legs already know it. They have been telling you about it for months, possibly years. The heaviness that settles in by midday, the fatigue that hits earlier than it used to, the feet that stay cold no matter how many socks you wear, the feeling that your legs simply will not respond the way they did before, not from age, not from lack of effort, but from something the medication is doing to the blood that reaches them. That is not aging. That is pharmacology. I am Dr. Mary, and today I am going to show you the exact mechanism behind what your legs have been experiencing, what the research says about it, and what a real conversation with your doctor can look like without stopping a single pill. I want to tell you about a man I will call Harold. Harold was 69. He had been on Metoprolol for 4 years, prescribed after a hypertension diagnosis. His blood pressure was well controlled. His cardiologist was satisfied. His blood pressure needed managing, and for that, the medication was doing exactly what it was designed to do. That is worth saying clearly before anything else. But Harold's legs had changed. He had been a golfer 18 holes every Saturday for 30 years. Somewhere in year 2 on the medication, he noticed he could not finish the back 9 without stopping. Not because he was winded, not because of chest pain or breathlessness, because his legs felt like they were filled with sand. He started taking a cart for holes he had always walked. His feet were cold from the moment he woke up until mid-morning, regardless of the season. And by 4 p.m, his legs had a heaviness he could not shake no matter what he did. He mentioned it at his annual physical. He was told it was probably just age. He was 67 at the time. Harold's legs knew what was happening before anyone named it. Let me show you what they knew. The first thing happening inside Harold's legs was this. Beta blockers work by blocking beta adrenergic receptors, the receptors your body uses to respond to adrenaline. When you are active, your body releases adrenaline to drive your heart faster and harder, increasing cardiac output, the total volume of blood your heart pumps per minute. That increased output is what delivers the oxygen and fuel your working muscles need to keep going. Beta blockers blunt that response. They cap how high your heart rate can climb during exertion. At rest, this is exactly what a heart under pressure needs, a calmer, more protected rhythm. But when your legs need more blood because you are walking, climbing stairs, or playing golf, your heart cannot deliver the volume it normally would. Think of your legs as a work crew that depends on a delivery truck. Beta blockers do not stop the truck. They slow it down and limit its load. At rest, that is fine, the crew is not working hard. But the moment the job picks up and the crew needs more supplies, the truck cannot keep pace. The materials arrive late. The crew stops. The job waits. That is the sand-filled feeling Harold described. Not muscle failure, not weakness, a supply shortfall. His legs were capable. They just could not get what they needed fast enough when they needed it most. A 2021 study published in Current Research in Physiology confirmed that beta blocker therapy measurably blunts the cardiorespiratory response during exercise, reducing both heart rate increase and cardiac output, with perceived exertion rising significantly even at lower workloads than before the medication. The same walk that felt easy before the medication now reaches your legs' ceiling at a lower level of effort, not because your legs are weaker, because the supply line driving them has been intentionally and therapeutically throttled. That is mechanism 1. But Harold also had a second thing happening. And this one explains the cold feet, which is a completely different problem with a completely different cause. Stay with me here, because the second mechanism is the one most patients never hear named. And once you hear it, you will understand something about your own circulation that you have probably been trying to explain for years. Picture a pair of scales. On one side sits vasodilation, the signal that opens your peripheral blood vessels and sends more blood to your hands and feet. On the other side sits vasoconstriction, the signal that narrows those vessels and reduces flow to your extremities. In a healthy system, these two signals balance each other. Your body uses both continuously, adjusting moment to moment to manage temperature, blood pressure, and circulation to your limbs. Beta blockers remove a weight from the vasodilation side of that scale. They block the beta adrenergic signal that promotes peripheral vessel opening. The vasoconstriction signal, driven by alpha adrenergic receptors, which the medication does not block, is left largely unopposed. The scale tips, and the blood flow to your feet and lower legs goes with it. The result is what Harold experienced every morning. Feet that stayed cold, skin in his lower legs that felt cool to the touch, a circulation quality in his extremities that felt reduced, not painful, not swollen, just diminished. Different from before. Less than it used to be. A systematic review and network meta-analysis published in the British Journal of Clinical Pharmacology examined this effect across multiple beta blockers and found a meaningful prevalence of peripheral vasoconstriction symptoms, cold extremities, reduced peripheral perfusion with significant differences between medication types. Non-selective beta blockers like propranolol showed the highest rates. Vasodilating agents showed the least. After 60, your peripheral circulation is already operating with less reserve than it had at 40. Add a medication that tips the vascular balance further toward constriction, and the symptoms that arrive can feel indistinguishable from what people call poor circulation or age. They are poor circulation, but the medication is a measurable contributor to it. And that distinction is important because it changes what the right response looks like. Now, Harold had both of these mechanisms working on him at the same time. His metoprolol was capping the cardiac output his legs could access during exertion, which explained why the back nine became impossible, and the sand-filled heaviness arrived by midday. And it was tilting his peripheral vascular balance toward constriction, which explained why his feet were cold from the moment he woke up, and his circulation felt like it was running below its old baseline. Neither of those effects made his medication wrong. His heart needed what the medication was giving it. But here is what most patients in Harold's position never find out. Not all beta blockers produce the same peripheral effects. And that difference between a standard beta blocker and a vasodilating one is the piece of information that changed Harold's life. Cardioselective beta blockers like Metoprolol, Atenolol, and Bisoprolol primarily target heart rate. They do less peripheral vasoconstriction than non-selective agents like propranolol, but they still tip the vascular scale. Vasodilating beta blockers, specifically carvedilol and nebivolol, work differently. They block beta receptors like all beta blockers do, but they also carry additional properties that promote peripheral vasodilation. Instead of tipping the scale toward constriction, they tend to hold it more level or even tip it slightly the other way. When Harold's doctor understood the full picture, the leg fatigue, the cold feet, the specific pattern of when symptoms hit, and how they felt, he did not add a medication. He switched Harold from metoprolol to nebivolol. Same blood pressure target, same cardiac protection, different peripheral profile. Within 8 weeks, the morning cold in Harold's feet was significantly improved. The afternoon heaviness came later and left earlier, and on his next birthday, he played 18 holes. All of them. With his own 2 legs. He did not stop his medication. He had a better conversation about which one. Here is what you can take from today into your next appointment. First, do not change or stop your beta blocker on your own. The cardiac reasons your doctor prescribed it are real, and the decision to adjust it belongs to the clinical relationship, not to a decision made alone at home. That is not a disclaimer, it is the truth about how this works. What you can do is name your symptoms with precision, because vague symptoms get vague responses. If your legs feel heavy or give out before anything else, does not from breathlessness, not from pain, but from a sand-filled fatigue that is specific to your legs, that is the cardiac output effect. Name it that way at your appointment. Not just, I get tired. Say, my legs stop before my breathing does. That one sentence shifts the conversation. If your feet stay cold in the mornings, or your lower leg circulation feels reduced in a way that is different from before you started the medication, that is the peripheral vasoconstriction effect. Name that too. Say, my feet are cold when I wake up and it takes hours to warm them. That is specific enough for your doctor to act on. Then ask one question. Given my leg symptoms, is the type of beta blocker I am on the best match for me? Not whether to take a beta blocker. Which one? Vasodilating agents carvedilol, nebivolol have a documented peripheral profile that differs from standard cardioselective agents. That is a real clinical option, and many patients are never offered it because the conversation about legs never happens in enough detail to get there. Tomorrow morning, before you take your medication, open your phone and write 3 observations. How your feet feel when you first wake up, how far you walk before your legs give out, and what time of day the heaviness typically arrives. Do that for 3 consecutive mornings. 3 mornings of specific observations brought to your appointment gives your doctor something concrete to respond to. And concrete is what changes prescriptions. 3 things to carry with you. 1. Beta blockers cap how high your heart rate can climb during exertion, which limits the cardiac output your working leg muscles can access. The sand-filled heaviness and the early fatigue are not weakness. They are a supply shortfall. The truck is running slow and your legs feel every mile of it. 2. Beta blockers tip the peripheral vascular balance toward constriction by blocking the signal that opens peripheral blood vessels. The result is reduced circulation to your feet and lower legs' colder skin, a diminished feeling, a baseline that is lower than it used to be. This is pharmacology, not age, and the two are not the same thing. 3. Not all beta blockers are equal in their peripheral impact. The conversation about which specific agent best fits your heart needs and your leg needs is a conversation you now have the language to initiate, and it may be the most important thing you bring to your next appointment. Before I let you go, I want to plant something in your mind for next week. We have now covered 4 medications in this series: statins and what they take from your leg muscle cells, amlodipine and the prescribing cascade it triggers in your ankles, beta blockers and the 2 ways they reduce blood flow to your legs. In each case, the medication was doing its job. The problem was never the drug. It was the missing conversation about what the drug does to the system it was not designed to treat. Next week, I want to show you a medication that nearly every senior on 3 or more prescriptions has taken at some point. And the leg symptom it causes is the one that gets misdiagnosed more consistently than anything else I've covered in this series. Most people experiencing it have been told it is arthritis, or diabetic neuropathy, or age-related nerve deterioration. It is often none of those things. It is a documented nutrient depletion that targets a specific nerve pathway, and in many cases, it is fully reversible once you know what is causing it. Subscribe so you see it the moment it goes up, because if what we covered today made you look at the heaviness and the cold in your legs differently next week, is going to do the same thing for the tingling in your feet. And for a lot of people, that is the piece that changes everything. I will see you then. Take care of those legs.